The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor.
Welcome to Jerry Cahill's Living, Breathe, and Succeeding podcast series, The Path Forward with CF. This show was made possible through an educational program from Columbia University Medical Center and the Lung Transplant Project to the Boomer Esiason Foundation. So today is the day. You get the call. Now what? We decided to talk to Dr. Frank DeVideo and Dr. Salim Arcasoy about dry runs, the transplant, and your first breath after surgery.
Once the lungs are identified and judged appropriate, the recipient is brought to the operating room, the anesthesia is induced, and the operation is started. In that time frame, the donor surgeon has procured the organ, is likely flying or commuting back by driving or flying to our hospital with the organs. And we usually try to time the arrival of the organ and have the recipient ready to be implanting that organ with the overall thought in mind to reduce the time of preservation.
The experience after transplant is incredibly varied between patients. Typically, right after surgery, patient is sleeping, has a breathing tube, and is on a ventilator. If everything goes very smoothly, the breathing tube can be removed within hours of surgery, but typically we try to remove it in the next 1 to 2 days. When patients do wake up after their surgery, either a few hours later or in the coming days, typically they may experience a lot of pain. They may have difficulty breathing, although some of our patients go on room air, no oxygen immediately, and some of our patients also report that the first breath they remember taking was very deep and very satisfying. Unlike some other patients who can't even take a deep breath at all due to severe pain, and they feel like they want their old lungs back. Once the pain and chest wall restriction eases up in the coming days, breathing becomes a lot easier. One of the major recovery elements is clearance of secretions that occur in the new lung, which is incredibly difficult. There are certain types of injuries that occur during the transplant process that causes the airway lining to slough off and cause very thick, sticky mucus that patients find incredibly difficult to expectorate or cough up due to pain and other factors. So that becomes a very distressing factor. The other important issue during recovery is the initiation of all the new medications that we start. There's typically 3 anti-rejection drugs, about 3 to 5 anti-infection drugs, some of which are intravenous antibiotics to prevent pre-existing infections or to prevent opportunistic infections that can occur in the future. So patients have to get used to them. And then all the ill effects of these medications like nausea, poor appetite, constipation, in addition to pain, are quite distressing. So the recovery can certainly be very challenging.
So the surgery, the transplant per se, is the starting point. But the true story is once the patient gets home going forward.
I look at post-transplant recovery in phases. The immediate phase, which is the post-surgical recovery, the intermediate phase, which is the first year, and then long-term phase, which is beyond the first year. The immediate recovery period in our hospital is typically 2 to 3 weeks, but it ranges between as short as 6 days in the hospital to several weeks or months in the hospital, depending on how sick the patient was going into transplant, as well as numerous surgical and medical factors that go into play after surgery. We get asked the question about what a dry run is commonly by the patients, so I'd like to take a moment to explain what that is. That's a time when we call a patient in for potential transplant, and then after the waiting period, which may span from 2-3 hours to half a day, depending on where the donor is and what time the donor surgery is scheduled. After that waiting time, we may tell the patient that we're sorry, but the lungs are not of satisfactory quality, that we will not be able to transplant you today. So the patient goes home in a very disappointed state. So that's what a dry run is. Typically, it occurs because we have information about the quality of donor lungs that appears to be satisfactory. We invite a patient to potentially get a transplant, and during that time, our team members, the donor team, flies out or drives out to the donor hospital to inspect the lungs inside and out, and then determine during the donor surgery, which may be several hours later, whether they're of acceptable quality. And then that moment, our transplant surgeon, along with donor team's input, makes a decision about whether the lungs are transplantable or not. So during that phase, we may find that one of the two lungs that we call the patient in has a pneumonia, or it's severely traumatized and does not appear like it's going to function well after transplant, so we cancel transplant surgery for that patient.
It's not infrequent that we go out and come back empty-handed, and those are called, as you mentioned, the dry runs. In our experience, we're in about 40% dry run rate. The dry run rates are usually either for one or the other recipient that we bring in. Usually we bring in a recipient for 2 lungs up front and potentially a backup for a single in case 2 lungs are not available and that recipient that needs a double cannot be satisfied. Keep in mind that lung transplantation started in the mid-'80s. The true numbers have been done in the 90s, and we already know that the second decade is much better than the first decade for results, and we're hoping that the third decade will capitalize on the past experience.